Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article entitled Indeterminate Pulmonary Nodules at Diagnosis in Rhabdomyosarcoma. Are they clinically significant? A report from the European Pediatric Soft Tissue Sarcoma Study Group by Vaarwerk and others. My name is Alberto Pappo, and I am the head of the Division of Solid Tumors at St. Jude Children's Research Hospital in Memphis, Tennessee. My oncology specialty is pediatric oncology. In this report, Bas Vaarwerk and investigators from the European Pediatric Soft Tissue Sarcoma Study Group evaluated the significance of indeterminate pulmonary nodules at diagnosis in children with rhabdomyosarcoma, defined as the presence of less than 5 pulmonary nodules measuring less than 5 millimeters or 1 pulmonary nodule that measure between 5 and 9 millimeters. This analysis included 316 patients who were enrolled on the EpSSG RMS 2005 study for non-metastatic rhabdomyosarcoma from September 2005 through December 2013, and for whom chest computed tomography scans were obtained at diagnosis and were available for review. Treatment in the EpSSG RMS 2005 study was stratified according to risk group, pathology, post-surgical stage, site, nodal involvement, size, and age. All patients received multi-agent chemotherapy with ifosfamide, except for those with low-risk disease, vincristine and actinomycin D, and this triplet will be referred to as IVA chemotherapy. High-risk patients were randomized to IVA or IVA with doxorubicin, and after 9 courses, if in complete remission, were eligible for a second randomization between end of therapy and additional maintenance therapy with 6 courses of vinorelbine and cyclophosphamide. Local control was determined by risk group, tumor site, age, and response to therapy, and radiotherapy was given at week 13 in doses ranging from 36 to 51.4 gray. All chest computed tomography scans were reviewed by the local radiologist at the treating center, and data was obtained and recorded using case report forms. All computed tomography scans were performed with a minimum slice thickness of 3 to 5 millimeters. The median age at diagnosis for the 316 eligible patients was 5.4 years, and the median follow-up time for the cohort was 75 months. There were 249 patients who did not have pulmonary nodules. This accounted for 78% of the population, and 67 patients who at least had 1 indeterminate pulmonary nodule, which accounted for about 21% of the population. Patient and treatment characteristics were similar between the two groups. 80% of the patients presented with group 3 unresectable disease, 54% had high-risk disease, and 71% had favorable histology tumors such as embryonal histology tumors. 24% of patients received maintenance chemotherapy, and 77% of them were treated with local radiotherapy. A total of 100 nodules were identified in the 67 patients in this report. Nodules ranged in size from 1 to 8 millimeters. 69% of the patients presented with 1 pulmonary nodule. 92% of the patients had nodules that measured less than 5 millimeters, and 85% of the nodules were unilateral. The 5-year event-free survival for patients with indeterminate pulmonary nodules was 77%, and for those without nodules, 73.2%. These differences were not statistically significant with a p-value of 0.68. The 5-year overall survival rates were 82% for patients with indeterminate pulmonary nodules and 80.8% for those without nodules. The difference between these two groups were not statistically significant with a p-value of 0.76. There were no significant differences in outcomes based on the number or size of the nodules. Similarly, there were no differences in clinical outcome based on histology, fusion status, age, and type of chemotherapy received. Lung metastases developed in 3% of the patients with indeterminate pulmonary nodules and in 1.6% of the patients without nodules, a value that was not statistically significant. The authors conclude that the presence of indeterminate pulmonary nodules in newly diagnosed children with rhabdomyosarcoma, as defined in this report, does not adversely affect the outcome of these patients, and these children can be adequately treated with non-metastatic risk-based clinical protocols. This report highlights the challenges of assigning risk and therapy based on the presence of a limited number of small pulmonary nodules in children with newly diagnosed rhabdomyosarcoma when they are detected using newer imaging modalities such as thin-cut computer tomography of the chest. The authors have successfully demonstrated in this retrospective study that newly diagnosed patients with rhabdomyosarcoma who present with indeterminate oligometastatic disease to the lung, which is in this study defined as the presence of 4 or fewer pulmonary nodules measuring less than 5 millimeters or one nodule that measures 5 to 9 millimeters, have similar outcomes to patients who present without pulmonary nodules. More importantly, these patients can be treated with less intense trials that may include the use of whole lung radiotherapy, which is known to significantly increase the risk of breast cancer in childhood cancer survivors. The authors have implemented a standardized definition of indeterminate oligometastatic lung disease, which is highly reproducible and easily implemented. Their results are thought-provoking and deserve further validation in a well-designed prospective clinical trial. Because of the lack of pathologic correlation with imaging findings in this report, it is not possible to determine which patients truly had oligometastatic disease to the lung. It is conceivable that some of the 67 patients with indeterminate nodules did not have actual metastatic rhabdomyosarcoma in the lung, or alternatively, these results may also indicate that current risk-based therapies for localized disease are effective at eradicating small oligometastatic disease. It is important to point out, however, that in this report, about 1/4 of the patient population was assessed using reconstruction widths of less than 1.25 millimeters, which might have identified a larger number of small nodules of uncertain significance. In addition, 69% of the patients with indeterminate nodules had only one nodule, 92% had nodules that measured less than 5 millimeters, and 85% had unilateral disease. All of these factors have been associated with a significant lower likelihood of identifying biopsy-proven metastatic disease in pediatric patients with sarcomas. These findings raise questions as to whether thin cuts less than 5 millimeters in thickness are of any value in the assessment of pulmonary metastases in children with rhabdomyosarcoma. In summary, this report opens new areas for clinical research that could lead to a uniform strategy for defining metastatic pulmonary disease in pediatric rhabdomyosarcoma and a more precise method for risk stratifying disease in this patient population. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.